All right, let's jump right into this high-yield explainer. Today, we're going to help you completely master the Poxvirus differential diagnosis for your board exams. If you've ever found yourself staring blankly at a clinical vignette, second-guessing whether a rash is Mpox or chickenpox, well, you are definitely in the right place.
Picture this for a second. A patient presents with a fever, severe malaise, and a centrifugal rash. So how do you choose the right answer when the options look so incredibly similar? Examiners absolutely love to blur the lines between these viral presentations because on the surface, they share a ton of features. But as we're going to see today, the devil and the correct answer is always in the details.
Here's our quick roadmap to get there. We're covering the exam challenge, transmission and prodrome, rash details, mortality and treatment, prevention, and finally, some essential bonus trivia. Let's kick things off with Section 1, the exam differential challenge. The absolutely crucial point here is that high-stakes exams are going to test your ability to spot very specific pathognomonic keywords hidden right there in the patient descriptions. You aren't just memorizing facts, you're basically learning to read the examiner's mind. By differentiating the orthopoxviruses like smallpox and Mpox from the herpes virus that causes chickenpox, you're going to be able to instantly anchor your diagnosis. Moving right along to Section 2, transmission and prodrome features. Basically, how it all starts. Okay, so chickenpox spreads like wildfire via respiratory routes, boasting a massive 90% attack rate with an incubation of 10 to 21 days. But the orthopoxviruses, they operate a bit differently. Smallpox relies on respiratory secretions and close contact with a 7 to 17-day incubation. But check out Mpox. While it can definitely spread the respiratory droplets, transmission heavily involves direct skin-to-skin or sexual contact. And that was actually the hallmark of the Clade 2b global outbreak in 2022. Now, before the rash even shows up, the patient hits the prodrome phase. All three of these viruses share a prodrome of fever and malaise. For chickenpox, it's usually pretty brief and mild. For smallpox and Mpox, it's definitely more pronounced. But if they all cause fever and malaise, how on earth do you tell them apart early on? Well, there's one massive differentiator you absolutely have to look out for. And here it is, the golden ticket, lymphadenopathy. If the vignette mentions swollen lymph nodes alongside that fever and malaise, boom, your diagnosis is Mpox. This is the key distinguishing feature because lymphadenopathy is definitively absent in smallpox. Seriously, highlight this in your mind right now. Examiners will use this single word to point you directly to the correct viral clade. All right, Section 3, rash, distribution, and progression. So once that prodrome clears, the main event begins. Mpox and smallpox actually share a specific identical pattern of rash distribution that contrasts sharply with chickenpox. Medical exams love testing this exact terminology, so let's make sure we clearly define what these distribution patterns actually mean for your patient. First step, smallpox and Mpox are described as centrifugal. Think of centrifugal force, pushing things outward away from the center. This means the viral lesions are going to heavily involve the face, the arms, the legs, and this is absolutely crucial, the palms and soles of the patient. The trunk just gets a lot less action compared to the extremities. On the flip side, chickenpox is centripetal. This means it focuses squarely on the center of the body, the trunk, and generally spares the palms and soles. So if a test question describes a patient with lesions covering their chest and back, but their hands and feet are totally clear, you're looking at chickenpox. If the palms and soles are involved, immediately pivot your thought process back to smallpox or Mpox. Beyond just the distribution, it is super important to understand how these lesions evolve over time. That journey from macule to papule to vesicle to umbilicated pustule, and finally down to a scab. This is another classic exam separator right here. Smallpox and classic Mpox lesions generally progress synchronically. That means every single lesion on a specific part of the body is at the exact same stage of development at the exact same time. Chickenpox, though, is polymorphic and asynchronous. In a chickenpox patient, you're going to see a brand new blister sitting right next to an old, crusted-over scab. Now, a quick aside. The 2022 Clade 2b Mpox outbreak did show some atypical asynchronous lesions, but for classic textbook board purposes, just remember, smallpox is synchronous, chickenpox is polymorphic. Let's step into Section 4, mortality and medical treatments. Notice the stark difference in mortality here. Smallpox historically carried a terrifying mortality rate of up to 30% in unvaccinated folks. 30%. Chickenpox, on the other hand, is mostly benign, though it can cause varicella pneumonia in about 20% of infected adults. Mpox kind of falls right in the middle, but it depends heavily on the strain. Clade I from the Congo Basin is more severe with a 1.4 to 10% fatality rate, while Clade IIb is under 1%. Now, as for treatments, chickenpox gets a cyclovir. But the orthopox viruses, they require something with a little bit more firepower.
For severe orthopoxvirus infections, tecovirimat, also known as ST246, is your absolute go-to drug. It works by inhibiting the viral egress protein, P37, essentially trapping the mature virions so they literally can't spread from cell to cell. But here's a critical board fact. Tecovirimat is merely virus-static. It's not virucidal. It stops the virus from spreading, sure, but it requires the patient to have an intact immune system to actually clear the infection. That's exactly why in Mpox patients co-infected with HIV, optimizing their antiretroviral therapy is arguably the most important intervention to ensure recovery. Oh, and a fun fact to remember for prescribing, the oral formulation actually has to be taken with a fatty meal for proper bioavailability.
Section 5. High-yield prevention and vaccines. So, while chickenpox utilizes the live attenuated OCA vaccine, Mpox prevention relies entirely on smallpox vaccines. The source text explicitly highlights 2 specific smallpox vaccines that you absolutely must be able to confidently differentiate on an exam, especially when you're dealing with vulnerable patient populations.
The critical difference here comes down to replication. JNSOS is a live but non-replicating vaccine given subcutaneously in 2 doses. Because it doesn't replicate, it is totally safe for immunocompromised patients. ACAM2000, however, is a live, replicating vaccinia virus. It's administered with a single percutaneous poke using one of those bifurcated needles. Because it replicates, ACAM2000 is strictly contraindicated in the immunocompromised. Getting these 2 mixed up on an exam, or worse, in a clinic, is a massive red flag.
And speaking of vaccines, get this. Amazingly, historical smallpox vaccination, even if received 3 to 19 years prior, provides a staggering 85% cross-protection against Mpox. 85%. It's just a really powerful testament to the structural similarities within the orthopox virus genus.
Finally, we've arrived at Section 6, Essential Poxvirus Bonus Trivia. All right, rapid-fire time. Burn these buzzwords into your visual memory right now. First, poxviruses are totally unique among DNA viruses because they replicate solely in the cytoplasm, not the nucleus. They also look brick-shaped under an electron microscope. Next up, molluscum contagiosum. This presents with painless, pearly, umbilicated papules. It absolutely cannot be cultured in vitro, and biopsies reveal pathognomonic Henderson-Patterson bodies. And finally, if an electron microscopy question mentions an ovoid structure with crisscross spicules, they are definitely talking about a parapoxvirus, like Orf from sheep. And just like that, we've decoded the clinical matrix. You are now fully armed with a structural framework to confidently conquer literally any poxvirus question they throw your way. So I'll leave you with this thought. The next time you're faced with a massive, complex rash vignette, which single keyword, lymphadenopathy, centrifugal, or synchronous, will you spot first to give away the entire diagnosis? Keep that in the back of your mind, get out there, and absolutely ace that exam.